Hi everyone, I'm Will. I am I guess the senior fellow in neurosurgery at Gosh. And Mike asked me or gave me this title of Neurosurgical Emergencies, what people need to know. Bear with me, I'm just going to shut that down if I can. It's a bit better. I can't see anyone now. No, that's worse because now I can't see anyone to talk to. Oh, I hate these computers. I'll just talk. I'll pretend you're my audience. So I guess the first thing, and I know you should never start a presentation with an apology, but I was planning to kind of polish this over the last hour, but have actually spent the last hour trying to get my camera to work. So apologies for that. There's a few. It's not quite as shiny as I would have liked, but anyway, I am going to hopefully. No, I'm not because it won't work. There we go. So the overview of what I'll talk about. So I'll start with some general principles, talk about the APLS algorithm, and from there sort of go on to some signs of raised ICP, look at the use of mannitol or hypertonic saline, whichever you prefer, and a little bit on dexamethasone. And then I'll just go through some emergency cases. Again, I was hoping to put more in, but time got the better of me, so I've just put some trauma cases in, some hydrocephalus and some brain tumors. So I hope you'll find some use at least in that. Good. So this, as I'm sure you all know, is the APLS algorithm for the management of coma, and this is all very much your bag. As you'll be much more happy in this in the center part. I don't know if you can see my arrow, but in the center part of the algorithm, and really we get involved that right down at the bottom down here when you've made a decision about intubating the child and you're at this this reassessed phase, and the question really is, does the child have signs of raised ICP? And then you're into your raised ICP management and informing specialist teams. So yeah. What's that? Sorry, my phone's going. I'm just making sure it's not you. So signs of raised intracranial pressure. So cerebral irritation, pupil signs, cardiovascular instability, and we all think of Cushing's triad, and obviously the Glasgow Coma score. So cerebral irritation. I remember a child when I was working at Alder Hey who had a serious head injury, and it's that sort of unable to settle, just writhing around, thrashing, panicked almost, really. Obviously you have the low GCS side of things as well, but that cerebral irritation is really just an inability to settle, or to reason, which when you've seen it, you'll know what that is. I think so the pupil response. So I've added a little bit of sort of basic, I hope it's not too basic, discussion about the pupil response. So in the eye, you have the two types of muscle. You have the dilator pupillae, which is controlled by the sympathetic nervous system. So this is the fight or flight response, and it's about opening the iris, letting in as much light as possible as you're about to fight or flight. So the sympathetic is the dilation of the iris, whereas the sphincter pupillae is the constriction, controlled by the parasympathetic nervous system. And again, this just reiterates that dilated pupillae, sphincter pupillae relationship. One, as I say, controlled by the sympathetic, the other controlled by the parasympathetic. The reason that the question that we're seeing here is, why do you get the dilated pupil? And it's because of the two different ways into the eye that the sympathetic and the parasympathetic take. So the parasympathetic arises in the hypothalamus, goes up the sympathetic chain, and enters the eye via the artery, as shown in the picture. Whereas the parasympathetic, again, as we know, enters via the Edinga valve, goes by and coats the outside of the oculomotor nerve, And the reason that you get so then the important point then to recognize is that the oculomotor nerve passes along the tentorial edge, which is again, as we know, the boundary between the cerebral hemispheres and the cerebellum beneath, and the nerve passes along the oculomotor nerve passes along the tentorial edge. So when you get a mass lesion within the hemisphere, it herniates the uncus of the temporal lobe, which sits around this area, around the tentorial edge, and forces that uncus down, and it pushes down onto the oculomotor nerve. So you get transtentorial herniation that causes a compression of the oculomotor nerve, what happens is you lose that constriction, you lose your sphincter pupillae, and so you get uncountered action of dilated pupillae. So that's why you see a pupillary response, is because the oculomotor nerve is being crushed, and the nerves of the parasympathetic line the oculomotor nerve. So that's why you see the pupillary dilatation. So that's the first sign of raised ICP that we look for. Cushing's triad. This is Monsieur Cushing. Actually, he was American, but yeah. So this is Cushing, very famous American neurosurgeon who founded the AANS, the American Society of Neurological Surgeons, which is nearly as good as the SBNS, but not quite, which is British, obviously. The Cushing's reflex. So the Cushing's reflex, we basically talk about hypertensive bradycardia, but the actual definition is a widening of the pulse pressure between the systolic and diastolic. But it's really that hypertensive bradycardia, and it's a response of the body to try and maintain its cerebral perfusion. So when the intracranial pressure is going up, you get the body reacts by increasing the blood pressure to try and or increasing the mean arterial pressure to try and maintain the cerebral perfusion pressure. So that's why you see this. And initially what you see is a hypertensive tachycardia, and although we all get excited about Cushing's reflex, really it's a late sign, a late and terminal sign. This is a graph from just a paper that I found when I was looking at putting this together, and what you see is this. So the black line being the pressure, the blood pressure that rises along with the intracranial pressure, and the heart rate that begins to drop off, associated with these apneic episodes and the irregular respirations. But again, in some respects, we shouldn't be letting it get to this stage, obviously. The key really is to look for hypertension with tachycardia. That's the early sign that you've got a child whose intracranial pressure is going up. Good. So I've got here. Go away. I've got here. Again, I'm not going to teach you how to suck eggs, but I'm just going to talk a little bit about the Glasgow Coma scale. This is Mr. Graham Teasdale, or Professor Graham Teasdale, sorry, from Glasgow, who came up or devised the Glasgow Coma scale. I put this here just to recognise that this is a recent phenomenon. I think the paper was 76. This is Anne Moore. She was the president of the SBNS, and they gave him the Norman Dot Medal for his contribution to neurosurgery, which is kind of the highest honour in neurosurgery. We all know this system. It's E4, V5, M6. Eyes is very easy. Spontaneous voice, pain none. Verbal, again, very easy. Orientated, disorientated, words, noises none. And then the motor, and it's always the motor that sort of get people. And as a neurosurgery registrar, it's kind of the bane of your life when you start picking apart what people are telling you in their GCS. And GCS of 0 is probably the worst one you get, but yeah, so I think the problem really lies in this distinction between decerebrate posturing and decorticate posturing and what that means, and people get really sort of caught up in that. So I guess if we just focus on that, so decorticate posturing is this bending up of the arms. People talk about the boxer, but it's the upper limbs are flexed, and the lower limbs are extended, whereas the decerebrate posturing is that all four limbs are extended. It's in a way it's kind of small print, and you can get sort of too hung up on it, but the anatomy of it's actually quite interesting, I think, as a neurosurgeon, and hopefully you do. But it's to do with the level of the injury, essentially. So in a decorticate injury, it's this slightly higher level of injury. So your brainstem is essentially intact. It's all to do with the position of the red nucleus, but what happens is you lose your corticorubral tract. Oh, sorry, bear with me. So you lose your corticorubral tract, which essentially has an inhibitory impulse over the cerebellum. So when you lose that impulse, that the cerebellum, it's the cerebellum that's making you do this. So decorticate is you've lost that higher cortex, essentially, and it's the unobstructed or unimpeded action of the cerebellum that's making you adopt that posture of the upper limbs. Whereas a decerebrate is where the lesion or the compression is distal to the red nucleus. So in that effect, you are losing both your you're also knocking out your cerebellum, essentially. So you're losing that control of the cerebellum, and that's why you get the forelimb extension, which is the spinal reflex that you're seeing, basically. So yeah, so I think that's quite, and I appreciate it's a bit small fry, but it's interesting anatomy, so I included it there. And then so medical management of raised ICP, and again, I think you guys probably know more about this than I do in many ways. I mean, we only really use, well, I guess 3 drugs in neurosurgery: steroids, mannitol, and antiepileptics, which we tend to leave to the neurologist these days anyway. But yes, I've sort of divided this up into A&E interventions. So I just got this from the doses from the BNF, but it's much easier in adults. You just say 200 mils of 20% is what I give for an adult. But in children, obviously, you have to titrate to their weight. So as I'm sure you would check the BNF and get this right. But the other things that are vitally important that are often overlooked are temperature control and glycemic control. Now, and of every intervention that's been examined or studied, glycemic control is the best prognosticator of outcome from head injury. So it's super important to do the simple things right. So yeah, temperature control and glycemic control are really key to outcome, as well as all the other clever things that we do. But the other thing, so bedside interventions are to nurse with the head up, just to encourage venous drainage and reduce the intracranial pressure. And the other key thing as well is to loosen the neck. If they're intubated, is to make sure there's nothing constricting the neck, because I'll never forget a time when I was asked. Well, we were basically on the cusp of doing a decompressive craniectomy on. It was an adult, but it was I think it was a RTA or head injury, and we went to see the patient, and they had an anaesthetic tie basically that was impeding their neck, and all we did was just go and undid the tie or just loosened it, and his intracranial pressure came right down. So it was kind of what do you call it, like a holy moment. but yeah, it's really something simple to consider, is to make sure there's nothing obstructing the venous outflow from the neck. And then the ITU interventions that, again, I don't know if you guys get involved with, but and as we know, we work with sort of hyperventilation, blow off the CO2. Obviously, that has the risk of cerebral vasoconstriction, so you only have short hits with hyperventilation. It's really a holding measure while you get your ducks in order in terms of whether you're going to offer decompression or whether further surgery is indicated. Burst suppression, sedation, inotropic support to drive the mean arterial pressure. Again, that's becoming less vogue, but in many cases necessary, and seizure control. The other thing I wanted to mention about using mannitol and hypertonic saline is it's in many ways, before using it, I would speak to the neurosurgical team. The only reason being that I tend to hold giving mannitol or hypertonic saline. My advice is always to have it drawn up and ready in a syringe in the ambulance, but to hold off giving it until you see evidence of, well, really a blown pupil is the sign that I would use. I mean, you can argue that that's too late, but in some ways the problem, giving mannitol, you only really have one good hit, and it gives you that window to intervene. So really you want to kind of, in some ways, keep your powder dry and wait until you really need it, and then give it, and then the clock's ticking. The reality with mannitol is it genuinely shrinks the brain, and what you see if you use it intraoperatively, because occasionally we have to, and what you see is the brain actually shrinks down. Now, if they've got a big subdural or extradural, you can actually make that worse by shrinking the brain. So it's not something just to use without considering it. So I would urge you to speak with the neurosurgeon before starting that in many ways. Obviously, if the kid's crashing and you need to, then such is life. But yeah, good. Oh, I put this in. This is one of the slides I was going to touch up. I haven't put the dose of dexamethasone here. I mean, I just tend to use a dose of 2 milligrams, either BD or TDS, depending on the size of the child, or 4 milligrams BD. Again, it's really titrated to the age of the child. I haven't got an exact measure. I'm sure the BNF has, but it tends to be a little bit arbitrary. Which probably isn't good science, but it is the way that we tend to do it, depending on the pathology and depending on the child's weight. But I just put in here that dexamethasone is essentially to treat has been shown to treat vasogenic edema. We don't really know how dexamethasone works, but they think it's to do with a VEGF mechanism, the vasoactive. Oh God, I can't remember what it is now. VEGF mechanism that stabilizes the wall of the endothelium, and so prevents that fluid leakage across the endothelium. So the dexamethasone is indicated in vasogenic edema. The other type, there's lots of types of edemas. The main types being cytotoxic and vasogenic. Cytotoxic edema is associated with ischemia, head injury, and it's to do with damage to your Na plus K plus ATPase pump in the wall of the cells. So the cells can no longer maintain their integrity. They soak up the fluid into the cell, and that causes a reduction in the extracellular compartment, which then leaks out of the vessels. So that in cytotoxic edema, the endothelial the wall of the endothelium is intact. It is competent. but it's just it's fluid shifts within the cell that cause the fluid to leak out. So in many ways, dexamethasone isn't indicated in cytotoxic edema, although the lines seem to be getting more and more blurred, especially with vascular cases. People seem to be using dexamethasone more for vascular cases. There was a big study recently looking at steroids in head injury. I don't think, to my knowledge, it's reported yet. Yeah, watch this space for that, I guess. Yeah, so really dexamethasone is indicated for vasogenic edema, so edema associated with tumors. But its role in other types of edema is unclear. I guess that's what I'm trying to say with this slide. Okay. So this is again from APLS. You know this better than I do, but child with decreased conscious level. So the areas that I guess the neurosurgeon that we get involved are in terms of trauma. So intracranial hemorrhage, brain swelling, cerebral or extracerebral abscesses. The phrase is always "never let the sun set" on an abscess. I was hoping to add some cases for these, but yeah, time got the better of me. So neurovascular events in children. This is classically secondary to an AVM, an arteriovenous malformation. Cerebral tumors, as we've mentioned, and hydrocephalus, including interventricular shunt. So this is just taken straight from an APLS. So I'll just switch gears now, and so that was kind of the basic teaching on signs of raised intracranial pressure. So we talked briefly about the cerebral irritation, the eye signs, the pupillary dilatation, and the mechanism underlying that. The Cushing's reflex, with the Cushing's triad of the hypertensive bradycardia with apnea expels. We also looked at the I can't remember myself now. We also looked at so eyes, Cushing's reflex, and GCS, and just looked at the mechanisms of the two pathways in terms of decorticate and decerebrate posturing, and then we looked at the management of raised intracranial pressure, the medical management, and talked a bit about mannitol, hypertonic saline, and the mechanism of action of dexamethasone. So that was the beginning of the talk. How far have I done? 25 minutes, just about right. And so now, as I say, we'll switch gears and just look at some cases. I've literally just gone through my my book of cases and just pulled out the last few that I could find. So I hope they're useful in some way. But yeah, so just a little bit of again, I think I was going to change the order of these around. This was going to go last, but when you're in terms of head injury, if we start with that, I think it's a good practice to really think of this on a sort of outside-in approach and work through the different layers to describe what has happened. So the first thing to think about are scalp lacerations, skull fractures, and with skull fractures we talk about whether they are a linear skull fracture, so a straight line fracture through, or you get this comminuted depressed skull fracture. The question then is, when do we elevate a skull fracture? The truth is, if we don't have to, then we won't, because most skull fractures will remold, especially in young children. As we all know, they get the ping pong skull. So especially in young children, you wouldn't elevate a depressed skull fracture unless you really had to. And the indications for elevating a skull fracture would really be if the child were to develop seizures and you felt that the depressed skull fracture was impacting on on their seizures. So you thought that was playing a role in their seizure generation. That would be an indication to intervene. Alternatively, obviously, if it was a dirty fracture, so if it was open and you had to go in and debride the tissue that was there, as a rule of thumb, we tend to say if the outer table has gone beyond the inner table, then we would consider elevating the skull fracture. But yeah, so again, starting from the outside, you think about scalp lacerations, then skull fractures, pneumocephalus, so air inside the head, which shows up beautifully on CT. And then you move on to your different definitions, and I know you all know this, but so extradural hematoma. Extradural hematomas have this lens shape, so they look like a lens, so they're lentiform. And the reason they're lentiform is because they're held in place by the margin of the dura where it attaches to the sutures. So that's the reason you get this lentiform shape within an extradural hematoma. A subdural hematoma, so underneath the dura, that lines the surface of the brain, so it has this, it tapers towards the edge and it follows the contour of the brain. Going in again, then you get the intracerebral hematomas, so within the brain substance itself. So the position of the bleed is obviously critical to your surgery and also to outcome. So your outcome from an extradural hematoma, provided that you get in quickly, is good. But is excellent. I've seen kids walk out of hospital within days of massive extradurals with huge midline shift. Subdural hematomas indicate damage to the underlying brain, so the prognosis is far worse with a subdural, and similarly with an intracerebral hematoma, again prognosis is worse, and you also then worry about brain swelling with an intracerebral hematoma, and contusional blossoming, which is where just like a bruise anywhere in your body, it starts to swell and grow, and that's often something you see after head injury. And I've just put in the end there just a traumatic subarachnoid and a diffuse axonal injury as two other examples of head injury. Yeah, so this is a case we saw, I think it was before Christmas. She was a really sweet little girl who was playing in her flat with her grandmother, standing on the back of a sofa, and the poor family, they lived in a social housing or council housing. I don't know the politically correct term, but it was social housing. And she had been complaining about this window that was loose for weeks, apparently. Anyway, she leant on the window fell out, and she fell from the first floor all the way down, and it was a basement underneath, so she fell about 15 meters onto her head. And she was GCS 3 at the scene. She was fitting initially the left upper limb and then generalized, and pupils were 2 millimeters bilaterally and reactive at that stage. So this was her presentation CT. So I don't know if you can see my mouse, but she's got this obvious extradural. So these are sagittal scans we're looking at here. You can see this obvious extradural hematoma here, and you can also see the extent of her fractures. If you look down at the bone windows on the bottom left, you see all these fractures running all the way through her brain. And if you look at the amount of contusion around the orbit as well. So this poor girl was in a really bad state when she got to us. So we did this operation, which is basically a bifrontal decompressive craniectomy, where you can see quite nicely on the scout here. I wanted to do the reconstructions, but the computer wouldn't let me. But so we've basically taken away this whole front portion of the skull to allow the brain to swell, essentially, which is what it's doing. So you can see the contusions and the edema within the frontal lobe. But this girl was with us she was on ITU for over a week, tubed and ventilated. She had an intracranial pressure monitor in. We were monitoring that, but she actually seemed she had a fairly stormy course, but weathered it quite well. And I was fortunate enough to see her in the outpatient clinic, and I'll just play this video of her. I had permission to take this video from Mum as well, just to be clear. So yeah, so that's Hannah, and yeah, so a really fantastic result. So I guess she was GCS3 at the scene after a 15-meter fall, and we thought her prognosis would be dire, but kids are amazing. So I guess the key is don't lose hope with these kids. Just do everything you can, because they're amazing. And she was really inspiring, and was a great lesson for us as well. So yeah, so I think that's worth sharing. Good. So this is just another child, again, not really as descriptive as the last one, but he's a 5-year-old boy. He was crossing the road with his auntie, I think it was, that he'd just come out of school, and was walking across, or I think he may have run across, but a zebra crossing, but a car didn't see him, and he got caught under the wheel, and he was dragged for 50 meters underneath the car, and didn't before the driver stopped, essentially, and had this awful degloving injury to the right side of his head, with a complex underlying skull fracture. His GCS was good at the scene. Pupils were equal and reactive throughout. So this was him. Again, you can see this complex skull fracture on the side, on the right hand side, and this was his head injury. So I wanted to shine this up a bit, but these views are really helpful. The CT reconstructions, I'm sure you all know about these, but if you refer to the neurosurgery team for a child with a skull fracture, if you can get the first thing we'll ask for is the reconstructions of the CT, so that we can look at the skull fracture and work out the extent of the injury and what we need to do. So to prepare yourself for making the referral, it's really good if you ask your radiology team. If they report a skull fracture, then just go to your radiology team and say, can you do the reconstructions? And you'll save yourself that conversation with the neurosurgeons, because that's the first thing we'll ask for, because it's just so much easier to visualize the fracture and the extent of it if you have the reconstruction. So this was him. He had, again, this awful full thickness injury, and underlying this was just this just pieces of bone, really, that had been fractured. But I cleaned him up, sutured him up, and he did really well. And again, went home from hospital within 2 or 3 days. So and he's been fine since. Thankfully, there was no underlying brain injury, and we didn't have to remove a great deal of the bone. I was able to reconstruct most of it, so that was good. And he's doing really well, which is great. So yeah, I've only included those 2 traumas for the moment. So I guess with the trauma history, think about when you're speaking to the neurosurgeon, just think about the mechanism of injury. Obviously, that's key. The time of the injury, the GCS at the scene, the pupil signs, and any other injuries is really key in terms of prioritizing what surgery you do first. And often, well, not often, but I have been in situations where I've been working on the head while the cardiothoracic surgeons are working on the chest. So obviously it's equally important. So it's key to know what other injuries the child has. So the next one, excuse me, I'll have a bit of tea. So the second case that I was going to discuss was a hydrocephalus or a blocked shunt. So this was a very sweet 11-year-old girl. She had it was a kind of an autism spectrum, Asperger's type behavior, but she was ever so sweet, very concrete in her thinking. Congenital hydrocephalus, shunted at 4 days, never revised. 3-day history of frontal headache, no nausea, vomiting, alert, oriented. This is the sort of classic history that we get. GCS 15, nil focal. This was her CT. Sorry, this was her CT from the year before, and this was her CT. This was her most recent CT at the time of presentation. So you could see an obvious increase in the ventricular dimensions. So her shunt is blocked. And again, what we'll ask for if you call about a child with a possible shunt problem, again, the first thing we'll ask for is a CT head and a shunt series to see. And on the right here, this is a shunt series. So we get an AP and a lateral of the skull, and that allows us to look at the valve. So what you can see here, I should have zoomed in a bit, but what you can see here is this is the catheter, the interventricular catheter here. Again, I hope you can see my mouse, otherwise it's pretty hopeless. But you can't see that. Thanks, Mike. Mike, great. Good. So this is the interventricular catheter here, and that goes to what we call is a reservoir. So the reservoir sits here, and this goes down into the valve, and this is the valve that you can see sitting here, and then the tube comes down, and you can see the tube comes down her chest, down the front, down here, and then into the abdomen, and coils in her abdomen. So the tube in this case, you know, the shunt series shows that the catheter is all intact, everything looks to be in line, there's no obvious breaks. And often with kids who are shunted at birth, you quite often pick up breaks in the shunt catheter down the line, because what happens is they calcify along the shunt tubing because it's been in for so long, and over time just like any other calcification can snap, so you do often pick up disconnections with the shunt series. So it's really a critical or a key thing to get to the CT head and the shunt series. So she was revised. She had a proximal block. So we talk about proximal valve and distal blocks. So proximal being the ventricular catheter, valve obviously the valve, and the distal. And the way we do that is we open the old incision, we have a look at the valve, and then we attach a manometer, so a pressure tube, and see how it runs off into the abdomen. So we put a little bit of fluid in, and if it runs down into the abdomen freely, then the distal part is working, and then we test and see if the catheter's dripping and replace whatever's necessary. It's plumbing really, but it's posh plumbing, but it's nice. It is what it is. So I've just included one more shunt problem. So again, a shunt malfunction, similar story as last time. Congenital hydrocephalus, shunted at 7 days. It had this abnormal looking MRI in 2015, but was developmentally normal, high functioning. 4-day history of frontal headache. 2 days of vomiting and photophobia. Increasingly lethargic. Again, a classic shunt history of headache, photophobia, vomiting is what you see in this, and this increasing lethargy. Again, no real focal signs of note. Apyrexial, GCS 15, no focal neurology, and these are his scans. So this was his previous MRI in 2015, again, which noted the absence of the corpus callosum and some dysgenesis here. But anyway, moving on. But you can clearly see that the increase in the ventricular size as compared with the scan done in 2015. And again, this one I included just because it reiterates the importance of the shunt series. So again, what you see here is ventricular catheter. This is the reservoir. It's called a Methka reservoir, but it just sits. Methka is the make, but it sits here. This connects into the valve, and this goes down into the distal tubing. And you can see here on this side that you've got the tube, valve, tube, reservoir, valve, distal tubing. Everything's nicely in line. But what you see here, again zoomed in, you've got the interventricular catheter, the valve, and can you see there's a disconnection here between? So this part here should be connected to this part here, just like it is here. So this child had swelling around this area. You could actually feel it, palpate swelling here. And when we went in, you could see that this was obviously disconnected. So it was a fairly simple procedure. From memory, I think we did replace the valve because it looked a bit gunky. So we replaced the valve and pulled the tube up, and yeah, job done. And again, the child went home within a couple of days, so all good. But yeah, I guess the take-home message from this is really to get the CT head and the shunt series if you're worried about a child. It's really important to have the shunt series. It's also really helpful in the operation. Especially for the abdominal end, because you want to know where. Often these children have had lots and lots of abdominal surgery, either for shunts or for other things, but they may have lots and lots of scars on their abdomen. So knowing exactly where the shunt is can be really difficult. So it's a kind of heart drop moment if you get a child into theatre and you realise that you don't know where the tube is in their abdomen because they haven't had a shunt series. It shouldn't happen, but it's a fear that goes through you. So yeah. So whenever you refer a child with a possible shunt problem, get the CT head, get the shunt series is the take home. And I've just included on here. When you refer a shunt to the neurosurgeons, what they want is a shunt history. So and it's really simple, but if you get it right, it just makes life so much quicker and easier. But in terms of all you really need for a shunt history is when was the first shunt put in, where was it put in, and why. And you often. So many times I ask, why was the shunt put in the first place, and rarely has anyone actually thought to ask that question. But it's really helpful if you know that it was a neonatal shunt, or it was done for trauma, or this kid had an infection, or there are so many reasons why they may have had the shunt. But knowing the circumstances of their first shunt is really helpful. And the next thing to know is the revisions. So how many revisions have they had? Is this a child who presents regularly, or is this the first revision that they've had in years? It's important for lots of reasons, but also in terms of gauging their parents' anxiety around the shunt as well, is quite helpful. If you've got a child who has regular shunt problems, and the parents recognize the symptoms and they know this is what it is. Anyway, you get my point. Knowing how many times the shunt has been revised is really important, and the most important really is when the last shunt revision was. That's really key to know if they're still kind of in that infective window. It's something like 95-96% of shunt infections happen within the first couple of months following surgery. So if they're outside that window, the likelihood that they have a shunt infection is vanishingly small. Not impossible, because it does happen, but vanishingly small. So yeah, so knowing that when they've had the last shunt revision is really key. Imaging, we've talked about getting the CT head, and again, trying to get the old images is really important, because what you want to do is compare to old imaging. And if you've got old imaging on your system that we haven't got, then get that linked over as well. Or if we've got or you know, just try and source that old imaging. Sometimes it's you get patients who have just come to the area, but the parents might have hard copies and things like that. It's just something to think about to get those to get the ball rolling in terms of getting the old images is really helpful. And we've talked about the shunt series, and I showed the example of the disconnection. So again, really important to get that. And papilledema, as we all know, which is controversial at the moment in terms of how useful that is in terms of shunts. There seems to be a move against it, but yeah, again, one to watch out for. But it's certainly one that we ask for, is to comment on whether you see papilledema. Good. So I've just included a couple of oncology cases just to round up. I think I've got about 10 minutes. So oncology, excuse me. This was a 4-year-old girl, presented normally fit and well, presented with a 6-week history of headaches, worse on waking, which is really a key sign that we ask for. Obviously, that points towards possible hydrocephalus, because when the child lies flat, it reduces the venous drainage, so you get a raised intracranial pressure. So they tend to complain of headache on waking with hydrocephalus, vomiting, ataxia, afebrile, and she had all these post-fossa signs as well. So dysdiadokinesia, nystagmus, past-pointing ataxia, but interestingly, no papilledema. And you can see it probably best on the sagittal here, but this is there's a large posterior fossa tumor here. I mean, surgically, what we look for is the plane, whether there's a CSF plane between the tumor and the brainstem. You can see a bit of a plane here, so the white signal here, but at the top you lose your plane. So this surgically is a difficult prospect. I think this child had a medulloblastoma. But the point I wanted to show from this was really the hydrocephalus. So this is, as you all know, a flare image from an MRI, and what you see is this flare around the temporal horns and the frontal horns, and you can also see that the temporal horns are up. So again, there's this flaring around the horns of the ventricle, implicating raised interventricular pressure and hydrocephalus. So she went on to have this debulked. So the question really, and it can be quite anxiety making when as a surgeon when we take these patients, because obviously they have this child has hydrocephalus, but then the question is, should you treat the hydrocephalus or should you take the tumor out? Because the best treatment for this is to remove the tumor, because then that will treat the hydrocephalus as well. But it can be a bit concerning, shall we say, when you sitting on this overnight. But dexamethasone steroid medication gives you often gives you that window that you need prior to surgery, and you can see the child through with that. So yeah, and the problem is if you put an EVD into these children, so an external ventricular drain, if you drain their CSF, their probability of needing a shunt in the long term goes up significantly. So you're not really helping them by doing a shunt. You do occasionally have to do it, because if the child becomes unstable, then you wouldn't take a posterior fossa tumor out in the middle of the night, but you may have to do an EVD if the child is deteriorating. And I think this is the last one I've talked about. I've got, unfortunately, but new diagnosis, posterior fossa. Again, similar history to the last one. It's often this age group. It was a 3 weeks of occipital headache, dizziness. Again, this morning vomiting picture. He was born prematurely, and there were some concerns regarding his development, but he was again a very concrete, very sweet little boy. otherwise fit and well. No medications, allergies, and again, no cranial nerve deficit in this case. So this was again just another example. This is a pilocytic astrocytoma. So you can see the difference from the previous tumor, which from memory was a medulloblastoma. But this is you've got this central compartment, this nodule of tissue here, surrounded by cyst, and you can see that quite nicely on the axial here as well. You see this tumor nodule just sitting here, and this big cyst all the way around. This is a pilocytic astrocytoma. So he had this completely removed, and all the wall is gone, and the whole tumor is removed. I included this just because the kid wrote the boy wrote a letter to Mr. Jelani, which I quite liked. It says, thanks for saving my brain. Yeah, which I thought was rather cute. It's on the wall in the doctor's office at the moment. So yeah, I thought that was quite sweet. So I included that one. So coming to an end. So again, this is one of the slides I was hoping to put a little bit more onto. But with posterior fossa tumors, the two reasons that it is an emergency are brainstem compression, right, which is when you look for things like bulbar signs and neurology, and hydrocephalus. So those are the two things to think about with a posterior fossa tumor. They're the two ways it causes an insult that you should always have in your mind in terms of is the brainstem compromised, and does the child have hydrocephalus? Good. So to close it up, so in summary, we talked about the general principles. We went through the Apls algorithm and talked again about the clinical signs of raised intracranial pressure in terms of the cerebral irritation, raising the pupillary signs, the GCS, and yeah, I hope that was useful. We talked a little bit about mannitol and the medical management of raised intracranial pressure, and we had that slide on dexamethasone, just comparing vasogenic to cytotoxic edema. And we also talked briefly, I talked you through some of the emergency cases that I've had recently. Yeah, and I think that's all I have.
Well, thanks so much. That was fantastic. Have you got time for a few questions?
Yeah, definitely. I don't know how to have you. I don't know if I can make it so I can see you. I didn't touch anything when the thing was going on. Hang on. Oh, there we go.
Okay, good. So just before we get to the questions, I just want to flag up, because some people might need to leave. At 6:30 this evening, we've got Kish Mankad, who's the lead paediatric neuroradiologist at Great Ormond Street, talking about emergency neuroimaging. So that's going to complement this talk really nicely. So I just wanted to flag that up. But so some questions for you, Will, from the chat.
Yeah, please.
So, question from Heber: is dexamethasone used after head trauma? You mentioned that I think that there was a trial that's currently ongoing. Is that in adults?
Yeah.
An adult trial?
Yeah. I no is the answer. Yeah, there was a big crash trial going through, but I don't know where that's up to at the moment. Oh, is it crash? Oh, I'm sorry, I'm showing my ignorance now. It's been a while since I've been really involved with trauma. Thankfully you don't see it a great deal in children, but no, we don't. We wouldn't use dexamethasone in trauma at the moment.
Question from Ala Fadila: what's your experience with GCS or any other consciousness level assessment in neonates? Good question.
Well, I mean, good question. I mean, there is a different scale for neonates. Yeah, I think, I mean, my initial thought when you said that is I tend to use the experience of the neonatal nurses. In truth, I think is probably a good guide. If they're worried, then be worried. Yeah, I think partly it's about with neonates, you've obviously got the fontanelle, which makes life a little bit easier in terms of pressure monitoring, and with the sutures not being fused, you do intracranial pressure in neonates is a slightly different management. There isn't the same, rightly or wrongly, there isn't the same sort of urgency that we apply with older children with fused sutures. But yeah, I hope that answers. But I think the other thing is just seeing the child more than once, and repeatedly reviewing the child is key to knowing if there's been any change, to getting a feel for what their baseline is. And
measuring the head, simple things.
Yeah, measuring the head's quite a late sign though. That's simple things. But yeah, the fontanelle's probably the fontanelle and the sutural splaying, and yeah, the head circumference on a serial basis, as you say. Yeah.
When assessing a child who presents to A&E with an existing shunt, do they need CT head as well as the shunt series X-rays each time? Many children vomit for so many non-ICP related reasons, and just wondering if there was a way to rationalize the radiation, or do we always need to do the CT head?
I mean, that's the question we get loads, and we no one wants to expose children to unnecessary radiation. I mean, the way normally it's quite obvious actually. If and an experienced A&E team will normally make a good call most times. So I mean, my sort of pragmatic answer to that is I'm not the clinician with the patient. You have to make the decision as to whether you feel this child needs a CT or not. I think it's important. We talked a bit about shunt infections briefly, but you know, if this is a child who's had a shunt for years and now presents with pyrexia and vomiting, the likelihood is this isn't a shunt infection because the shunt's been in for so long. So I would rule out all other sources of the infection first before considering that this is the shunt. A lot of people jump for the shunt first, whereas really it's far more likely to be, you know, urine infection or chest infection or etc. So I guess I would say that I don't think you can have a strict protocol for when to do a CT head. I would say if you're going to do a CT head, do a shunt series, because the one without the other is just that doesn't make sense. So I would definitely do the two together if you're going to do it at all. But I think if the referring clinical team are happy to observe, you know, often they come with a really bad history, but when they get to A&E, they often say, you know, the mum says they've been sick for 4 days, but actually since they've been here, they haven't vomited, they've been fine, they've actually seen quite well. Then my advice often for those cases is, well, why don't you just observe them overnight? Any concerns, any deterioration, get a rescan. But otherwise watch them for the time being. But yeah, I think you have to do it on a case-by-case basis. I think, yeah, and just get the shunt series with the CT head, I guess, is the other thing.
And this is the point I made yesterday in the stroke talk, but it applies even more here. The radiation dose is actually less now because the protocoling is very focused on what the question is. And especially if the question is about hydrocephalus, they're not going to be taking fine slices. So, yep.
The other side of that coin, though, is if you've got a child, say, with craniosynostosis who's just having, you know, so much radiation. So I think it's something to always be cognizant of and to try and reduce. But I mean, the fast spiral CTs are so, the radiation is so small, it's almost negligible. Yeah, I agree.
Question from Nisha: can you get intermittent shunt blockage with fluctuating symptoms?
Definitely.
Okay.
Yeah, I mean, yeah, yeah, you can definitely, and but I mean, what you tend to see that in children with slit ventricles. So I'm sure you know what it is, but it's a phenomenon often associated with kids who are shunted at a very young age, and the ventricles sort of collapse down. You get very thin ventricles that aren't compliant, so they have no stretch in them at all, and they get a brittle form of hydrocephalus, and they're very, very shunt dependent. So what can happen is the ventricles overdrain and it closes down on the catheter, and then the child gets symptoms, the ventricles increase a bit, they open up, and then the shunt starts working again. So yes, you do, intermittent symptoms is concerning. It is something that definitely happens, and is difficult to treat. But it's what we would do is if there was sufficient evidence, we would interrogate the shunt to make sure it's working, but also intracranial ICP monitoring can be useful. So intracranial pressure monitoring, where you see if they have fluctuations in their pressures. It can be useful, but yeah, it's one to speak to the neurosurgeons about, put it that way.
Yeah. Has anyone tried to, this is more of a suggestion for the neurosurgical community, has there ever been any attempt to create a national database of shunts linking all the neurosurgical centres? I'm sure someone's tried that, haven't they? Like many large-scale projects.
Yeah, there's the Cambridge Shunt database, but that's really about the surgical techniques. It's more about surgical complications. It was set up actually to look at whether one valve was better than another. Was why the Cambridge Shunt Registry was set up. So it doesn't really have that sort of clinical overreach that would be really great for these kids. Yeah, yeah, it's certainly a project I'd love to take on, but yeah, another day.
Yeah, is cranial nerve involvement an indicator of bad prognosis in patients with raised ICP?
It's an indicator that they've got raised intracranial pressure, but it depends. Your prognosis is mostly dependent on the etiology of the injury. You know, I've seen kids with blown pupils with extradurals walk out of hospital within days, and similarly, you know, I've seen patients with seemingly small brain contusions with no eye signs who have died. So it's definitely important, and I think it speaks more to the urgency or the expediency of the intervention. If a child, it's an acute sign, but not necessarily a long-term sign. I think there are other prognostic indicators that are better than the eye signs. But it's an indication that you need to prioritize this child. And just a word on prioritization. If there's a few cases that you just have to get to your hospital and you have to intervene on straight away. And it was what one of the neurosurgeons at King said. And he said, if you really need to speed things up, tell them it's like a crash section. You know, that's the kind of urgency you need to get these kids over, and it gets the, no disrespect to anesthetics if there's any anesthetists around, but it focuses the mind on that expediency. So to use that terminology, think of this like a crash section that we need to get the child here now, and yeah, it's been a useful phrase for me.
Yeah. Use of dexamethasone as an emergency medicine in cases of posterior fossa tumor with raised ICP.
Definitely, 100%, absolutely key, absolutely key. Give them a big dose up front, and you'll get a massive improvement straight away. And it buys you that window, as I say. Yeah, undisputed. You have to give them, you know, a sort of a 4 milligram stat and then a 2 milligram BD or TDS. But give them that big dose as soon as you see it, and it'll save lives.
Another question from the same person, Heber. What's your opinion about using phenytoin in cases with raised ICP and hypoxic brain injury without seizures? So I guess prophylactic antiepileptics is the question, isn't it? In a high risk situation. Well,
I mean, I'd probably phone a friend on that one. But no, I mean, the evidence in head injury is that if you use phenytoin up front in the first 7 days, it reduces your risk of early seizures, but doesn't have an impact on late seizures. So in a head injury, I know you asked, I'm sort of swerving the question, but in head injury, we would indicate for the first 7 days. But I don't know, Mike, you're probably better at answering that than I am.
I think we would usually do an EEG, and that would help us to gauge the risk. Although that might not always be possible in certain neurosurgical situations. And also, if it was prophylactic, maybe we would prefer Keppra increasingly. Phenytoin is probably more effective and easier to be sure that you're giving an effective dose. But if it's just prophylactic, we might use Keppra. Someone mentioned for neonates, we can do cranial ultrasound as well. Yeah, that's a good point, actually, about the difference for neonates.
Yes, absolutely.
How do you manage slipped ventricle syndrome? I don't actually know what that is. Slipped ventricle syndrome.
Slipped ventricle. So I mentioned that briefly when we talked about intermittent shunt blockage. Thankfully,
slit with a T is what you're saying there, isn't it?
Slit, S-L-I-T, as in slit shaped. So
yeah, the person's written in the chat is S-L-I-P-P-E-D. Is that a thing? I think maybe they meant slit ventricle, which we've already discussed.
No, it's probably my northern accent. Sorry.
But anyway, you can explain it for people who might not know what a slit ventricle is.
Slit ventricles is in some ways your worst nightmare, to be honest. They're extremely difficult to treat and very, very shunt dependent, and very difficult shunt revisions as well, because the ventricles are so small. Yeah, I mean, it's probably not. This probably isn't the arena to talk about it. It's a bigger question, really. But thankfully, is the incidence of slit ventricles is probably going down due to the new valves that we're using. It's not gone completely, and you still see it in neonates shunted at. It's probably an over drainage phenomenon, where you overdrain the ventricles, they shrink down, and they lose compliance at that stage, either through gliosis or some sort of adhesion. And once you've lost that ability to compensate, it just makes life very, very difficult in terms of management. One option with these kids is to consider a vault expansion. So that's when you get into the realms of craniofacial surgery, and you talk about, you can take the bone away from the side. So a subtemporal decompression is one way of managing it, or a posterior fossa expansion in some cases. But it's really quite specialist stuff. It's genuinely difficult to manage.
Okay, one last question, which is my question actually. You mentioned never let the sun set on an abscess. So I take this to mean that you have to go in and operate if there's an abscess. Do you want to expand on that?
Yeah, I'm sorry. I wanted to include some abscess cases, but I just ran out of time. I'm sorry about that. But if I get invited back, I'll do it next time. But no, yeah. So it's one of the key phrases. One of the phrases in neurosurgery is never let the sun set on an abscess. The reason being that it's if a cerebral abscess ruptures into the ventricle, then the prognosis goes down significantly. If they develop a ventriculitis secondary to a cerebral abscess, then your morbidity is exponentially higher. Yeah, I mean, and then you're talking about whether you do a needle drainage, or an open operation. But again, that's a different question. But yeah, the never let the sun set is, if you have a diagnosis of cerebral abscess, get them in, get them drained, basically, straight away. Because the other thing with infection, as you know, is you get this microvessel ischemia. So you can have they can go downhill really quickly. So just get in and get them drained, basically. Yeah, I guess. Oh, the other thing I was going to say about abscesses that I didn't was that if you're querying, if you see a ring enhancing lesion, which is what an abscess essentially is. But if you see a ring enhancing lesion on CT or MRI, then make sure they do a diffusion weighted imaging. So a DWI is key to distinguish, because it tells you what the inside of the ring enhancing lesion is, and abscesses have a really clear appearance on that. That was one of the things I wanted to add. But yeah, if you're querying abscess, get a DWI MRI, diffusion weighted MRI is key.
Lovely. That links us perfectly back to the talk this evening at 6:30, when I'm sure Kish will tell us more.
Okay. Cool.
That's all the questions, I think. Will, thanks so much.
Very welcome. I've got a screen full of nothing, but there we go.
Yeah, there's not much feedback, is there? It's quite strange. But if you look on the chat, you'll see lots of positive comments. So thanks a lot.
Okay. Good. All right then. Are we done? Take care, everyone. Hope it was useful. Bye.